because I feel bad now. I feel bad now that I know you have patients waiting.
No problem. No problem.
So good morning, everybody. Thank you for joining Monty Hart again this week. We have really a fantastic speaker this week, Dr. Joachim Schofer from Hamburg, Germany. Joachim has spoken to us before on Monty Hart, and was a really excellent talk. He really is world-renowned in the field of structural interventions, and I've certainly worked with him and learned so much from working at your side and coming to Hamburg. And I remember I was telling somebody the other day, Joachim, how I learned about using a angioseal after the ProGlides from you. And this was about 8 years ago. You were already doing it. Now people are talking about it and they're publishing about it, and you were doing it long before everybody else, and so many other things. So we've had amazing opportunities to collaborate together, Joachim, on different valves and different procedures and new procedures. So I'm really delighted you can spend some time with us today.
Thank you so much for this very nice introduction, dear Azim, and congratulations to the acceptance of the paper and the European Heart Journal. Really very great achievement. So if you don't mind, I've chosen 3 challenging, hopefully challenging cases in structural heart disease, and maybe at some point I will just interrupt for a discussion.
Sounds good.
Yeah, okay. So let's go. I have nothing to disclose in relation to my presentations today. So the first case we entitled a time bomb, which nobody wanted to deactivate. So let's see what we have here. It's a 85 years old male patient presenting with acute chest pain and dyspnea. When he presented, his blood pressure was normal with no side differences, regular heart rate, gentle systolic murmur at Erb's point, no respiratory compromise. This patient had a history of 2 bypass surgeries, the last one with a Lima jump to first diagonal and at the LAD, and a Rima T graft to the PLA. Several years before, he had 2 vein grafts to the LCX and RCA. 2 months before this presentation, the patient experienced a non-STEMI and got a drug-eluting stent in the vein graft to the RCA. And 4 months before, he got a TAVI, an Evolut R 34 millimeters Evolut valve. If you don't mind, I tell it, I will call it TAVI instead of TAVR, but it's European.
We should all call it TAVI.
He then experienced a total AV block and got a pacemaker. Comorbidities were chronic renal failure, atrial hypertension, diabetes, and asymptomatic carotid stenosis and anemia. Current findings were an elevated troponin. ECG was not very helpful because of the pacemaker, and his echo showed an anterolateral hypokinesia with a slightly impaired LV function of 42%. The THV was obviously in good function. So the first suspicion was that this patient again has a non-STEMI, and this led to the coronary angiography. As you see on the left, the shot into the Rima graft showed a nicely patent arterial grafts to the left coronary artery system. And in the middle, you see the injection into both vein grafts showing a patent stent in the vein graft to the RCA. And surprisingly, there was nothing which could explain the acute chest pain and dyspnea of this patient. So for the next step in the workup of the acute chest pain, a TOE was performed. And what you can see here, this was surprising, that there is obviously a leak This is the evolute R valve. This is the upper part of the valve, and here you see a flow into a false lumen. Obviously, this is a aortic dissection. MSCT confirmed the finding with an entry tear of 7 millimeter, exactly at the distal part of the stent of this THV, and a perfused false lumen, which extended up to the innominate artery without re-entry and without compromising the supraaortic vessels and the coronaries. So the question was this TAD, was it present before the TAVR or during the TAVR? So the CT, we took a look to the CT. The CT before TAVR showed absolutely normal ascending aorta, and the same was true for the root shot we took after the TAVR was implanted. There was no dissection seen. So when we talk about Stanford type A dissection, we have to keep in mind that this has a very high mortality. The mortality rate is 1% per hour for the first 48 hours. 30-day mortality is around 90%, and it has been described also as a rare complication after transaortic valve implantation, with a reported incidence of 0.6 to 1.9%. And of course, surgery is the treatment of choice in these patients, but perioperative mortality is quite high. 25%, and neurological complication also remain quite high. So, of course, we asked the heart team, and maybe I can just bring this back a little bit that you can better see it. A heart team conference declined surgery. Declined surgery because of an unacceptable risk. That was at least the opinion of the surgeons, because of the age of the patient, the comorbidities in particular, because of the 2 sternotomies he had in the history, at a pretty high surgical risk. So the decision was to watchful wait and see what is happening. Patient came back 6 months later for a CT with an increase in the aortic diameter from 57 to 82 millimeters. So there was a concern for perforation. And again, the heart team conference was asked what to do. And after a long discussion, again, the surgeons declined surgery. But the patient barely wished treatment in anticipation of the perforation. So this was the time when this patient presented at our center. And his question, the question of the referring physician was, is there any endovascular option for this patient? So at this point, I would like to stop my presentation and ask you for your suggestions in this case.
Oh wow. You always have easy cases to show, Joachim. Thank you.
By the way, you know, this case was the case of the year last year in the German Society of Cardiology.
Oh wow! Wow.
Yes, yeah. But it's not. You know, I don't think it's really so very.
No. I think we've seen this before. So,
yeah.
I think maybe just a couple of things about like what happened here first before we talk about management. I mean, because when you look at the CAT scan, it looks like it's the outflow of the core valve.
Yeah.
Part of it has pushed into the wall, right?
Yes.
And I think we've seen that before. I've seen a couple of dissections with core valve. I mostly when the valve's embolized and you pull it up, and you can have the upper part of the frame or the tab go into the tissue with time and movement, and it damages and dissects. Because people think self-expandable valves don't cause perforations and they don't cause ruptures or dissections, but it's not true. I had another case also where, as we released the core valve, the top part hit the aortic wall and the patient fully ruptured completely and died, and we couldn't save the patient. So, I mean, these things happen, so it's good for the fellows to know. I'm not sure if our team has any suggestions, but percutaneously, I would look to see, it just looked, the entry looked very big. So normally I've thought about, can you put like a device, like a VSD type device or something there? But it may not be enough. So the other thing I've thought about is whether you can coil and put these large coils to create some thrombus outside, and then try and put a device like a big VSD device or something over that area to try and stop flow into that area. Because there are no grafts that I know of in the US at least that we percutaneously available that you can put there to create another aorta.
So my personal experience with dissection is, only I had two cases which are very similar to this one, with a time interval of several months or even years after the implantation. The acute event is always seen, for me, if you just try to retrieve the valve because it's embolized, and then you can have that. So of course. Okay, so we also asked a vascular surgeon, and who is very experienced also with percutaneous interventions, if there's any chance for coiling. He was quite reluctant in trying that. So we thought about, could we use a stent graft in this patient? And the only drawback here is that we have two vein grafts very close to the prosthesis. So if we would use a stent graft, we would occlude the vein grafts.
Right.
So this was not a good option. So,
and how would you have put the stent graft to seal? Because you look, I mean, almost looks like the stent of the valve is going into the pseudoaneurysm.
I think then you have to really bring the stent graft into the stent of the core valve.
Wow. Okay.
And you have to cut this. You have to choose the right length of it. So we didn't feel comfortable in doing that. Okay. So we looked for closure devices. Okay. Several are out, you just mentioned. The vascular closure device for us seems to be not, let's say, safe enough to implant, because it's available up to 14 millimeters, which I think should be too small for that entry point. It's only 7, but you have to take into account you have a very floppy membrane here, which doesn't serve as a stabilizer. Then in ASD or VSD occlusion, the drawback here is you have a stent in the middle between the two discs. And if you put this in here, we were afraid that we could extend the dissection. So we also felt not very good to do this. Finally, there is this DFO occluder, which doesn't have a stent, have a very tiny connection between these two discs. And if we take a cribriform occluder, we have a disc with equal sizes at each side. So we thought, okay, why not trying to do this, to take a PFO occluder just to try. If it fails, we can retrieve it. Okay, this is how we started. So the next question was, what size should we use? And I explain why we took a 25 millimeter device. If you look at the Evolut arm, our aim was to go through one of the gaps, to the distal gaps here of the stent, just to anchor this device here, that it could not flop, and it should be so big that we could just close the entry point. The extension of a 25 millimeter is by 12 millimeters, so this could fit. On the other hand, we would like to have this stent as a stabilizer, and then we have to take care that this is not extending too much into the stent, because the tip of the leaflet is about 12 millimeters apart from the upper part of the stent. So we take, okay, 12 millimeter, 25 millimeters should fit, because it should not in any way impede the leaflet movement. On the other hand, it should close the entry point. So this was the situation. And let's go to the procedure itself. Finally, it turned out to be quite simple, tell you. So we went from the femoral artery. We took the EMA catheter, 5 French EMA catheter, and made a loop with a stiff tumor wire in order to have enough backup for 8 French hook sheath. This is how we advanced it. You know, before we took care that we just went through one of these gaps of the stent in order to have a good stable position of the closure device. This is how we introduced the hook sheath. Let me go ahead. And then we took the occluder, and as you may see here, the distal disc did not develop completely. It just
wow.
Yeah, it's just incomplete. But we thought, okay, it's big enough not to go through the gaps of the stent.
Exactly,
So,
it'll anchor.
Leave it there. And then we just developed the proximal disc, as you see here.
Wow.
Okay.
Okay.
Now it sits. So, and then of course we took a lot of TE and fluoroscopy pictures,
wow.
and
wow.
you see,
wow. That's incredible.
We did the angio, and you know it's almost a complete occlusion. If you see a very tiny flow into the false lumen here below,
But that will thrombose. Wow.
The same is true here for the TE. I think quite a nice picture. So in theory, you said the left, this is in theory. In practice, this is a CT after we've done this. You see the occluder here, and this funny looking proximal part of the distal part of the disc. The patient came back 4 weeks later, and you may appreciate here an almost total filling of thrombotic material for the false lumen. This is the residual flow, which you can see here. And 12 weeks later, there was a shrinkage seen, which is expected if there's no flow, and the diameter went down to 55 millimeters, and the residual flow, as you see here, just was reduced by half. Okay, so we were very satisfied. The patient is now out for 2 years, is feeling well, and this is our learning point. Late Stanford type A dissection is a rare vascular complication after TAVI, in particular with self-expanding Evolut or self-expanding THVs. And the vascular closure of the entry to the false lumen is a therapeutic option in inoperable patients, and the choice of the occluder is important, is very crucial, and the THV stent can be used to secure and stable the device position. Okay, this is my first case.
That's wow, that's an incredible case. And I understand now, because I was thinking in the beginning when I was thinking which device you were going to put, the fact that you had to go through the stent of the core valve, and that's what really dictated what device you could put in, because you couldn't put anything with a waist then. You had to have something that did not have a waist.
Yeah, that's correct.
So do you think, the other thing I was thinking about, do you think like the Gore cardioform would have worked here too? Because, the fact that it's so covered with PTFE, maybe would have given a really good seal?
Yeah, I think so too.
Right.
We didn't have this available, but I think so too. I think this could be an option, of course. Wow. This is not the only device I think you could put in here, but it's more, I think one of the learning points here is that you could use the stent as a stabilizer. Yeah. Amazing
case. No wonder it was the best case at DGK. Great case.
Okay, shall we go ahead?
Please, I don't know if the fellows or anybody on the team has any questions about this case. Any of the fellows or Samina, if you put on your camera, go ahead.
Thank you so much for this great case. Amazing result. One question I have is, like, retrospectively, is there any anatomical feature on the CT pre-TAB or TAVI, sorry, that we could anticipate that this patient is at risk of having this complication, like a narrow STJ or something that you would?
A very, very good question, really. There was nothing, which could be an indication for such a complication. So the sizes were not unusual. The wall, the aortic wall was not calcified, was not ulcerated at that point. There was not a let's say, unusual diameter of the ascending aorta. No, nothing like that.
Thank you.
You're welcome.
Anybody else, team? I think everybody's still stunned.
It's too early, as in it's too early. Yesterday evening, I think the US team played versus
versus Wales.
Wales, did they win?
No, 1-1. I think 1-1.
1-1. Okay.
Yeah.
Okay. Yeah. Well, can be better.
Could be worse.
So the next case is a percutaneous treatment of severe coexisting valvular and paravalvular tricuspid regurgitation. Okay. A 70-year-old lady, she underwent a mitral valve repair using a 30mm Carpentier-Edwards ring in 2013. In combination with a tricuspid valve repair using a 32mm Carpentier-Edwards Physio ring. Shortly thereafter, she underwent AV node ablation because of uncontrolled atrial fibrillation and got a permanent pacemaker. The patient was fine for several years, and then she came back with gradually developing tricuspid regurgitation associated with severe heart failure. When she presented, she had heart failure, New York Heart Ambulatory 4. Her mitral valve maintained a good result, but the tricuspid was, as you will see in a few minutes, was awful. Comorbidities, diabetes, arterial hypertension, AFib. She had a pretty high surgical risk, and she was refused from surgery in 4 different centers before she came to us with the question, is there any alternative to a resurgery? Echo revealed normal LV function. Right ventricular function was slightly impaired with a TAP-C of 15 millimeters. And as you see in a minute, she had high-grade high-grade regurgitation due to a valvular regurgitation and a huge, as you may see here, paravalvular leak. The paravalvular leak had a size of 32 by 34 millimeters. This is the ring, the incomplete ring of the tricuspid, and this is the huge paravalvular leak. And within the leak, you see the lead of the pacemaker. So that's in the situation here. And I wonder, how we could help this patient.
Yeah, wow. So it's an incomplete ring with severe TR across it plus a lead, right?
Yeah, across the paravalvular leak and in addition, a severe TR, valvular TR.
Right.
So
and the ring looked well attached. It wasn't a hist, right, Joachim?
Yeah, it looked well attached. There was no rocking.
Right.
So
yeah, so I mean, what we've done in some of these, they're very complex, is we take a 29 Sapien, oversize it, and we close off, we anchor it on the ring, and then we've gone next to it and stuck plugs to close the residual leak, because you're always going to get a leak where the, on the part of the ring that's uncovered. That's what we've done in some of those. Nowadays, that there's dedicated valves, I would try and see if I could get the patient into, like an Intrepid study, but this looks too small for Intrepid, I must admit, because the smallest Intrepid is 42 millimeters. So I would be thinking, could I put a 29 Edwards oversized, maybe 29 plus a few cc's, 4 cc's, and then put plugs next to it?
Okay. So let's go from here. It's an incomplete ring. So the incomplete rings have always the disadvantage that it might be difficult to anchor and to achieve a circularity. So in this case, it was a 32 millimeter ring with a CT area of 580. Which fits to a Sapien 29 millimeter valve. So, but I think it's almost, it's fitting. It's a ring for a 29 millimeter valve. So we did not expect to really reduce the paravalvular lesion, the paravalvular leak, by just oversizing this ring, because it was too huge. The gap was really very, very tremendous. So the first task was to put the valve in, and then we thought, okay, then let's see what we can do for the paravalvular. But
oh my God!
You see here's the lead, which is in the paravalvular space. This is the incomplete ring. This is the mitral. This is the tricuspid incomplete ring. So what we had to use is a snare to bring this through this gap down into the ring in order to really have a good position, a safe position for the Sapien valve. So we went from two venous femoral veins. From the left, we had the snare to pull it down. Okay, after we've done this, we got a quite nice position here, and we implanted the valve, which was not very difficult to do. And here you see the valve is in a quite nice position, and you see it's functioning well. But what remains is this big hole here. Okay, so the paravalvular leak. This was the challenge now. Okay, again, when we talk about closure devices, In this case, we thought it would be good to use an ASD occluder because we need a really large disc diameter. And when you imagine we had a paravalvular leak, which was 32 millimeters. So we took a 32 millimeter ASD occluder, which has a distal disc, left atrial disc, which is then put, of course, in the RV of 46 millimeters. We tried it from the femoral artery, but we did not achieve a good angle, and we always got into conflict with the sapien valve. As you can see here, this was not a very good position. So we choose to come from jugular and again use the snare, but the snare from the groin, put it down to get the right angle for the implantation. And then we developed the two discs, and this was the point where we really had to test everything to see, do we have a good position here? Do we in any way impede the sapien valve, which you see is not really the case. There's a very small overlapping here. This is before deployment, and there is still a small hole. We thought, okay, maybe she can live with this, or we can come back and close it later. This is after deployment. You see the nice picture between the side by side of the occluder and the valve, and this is the reduction in the paravalvular leak. Still, there is paravalvular leakage, but not comparable to what we have seen at baseline. Patient came back 12 months later with no heart failure rehospitalization since the intervention. Her daily activities were without problems. She could climb 3 floors, and her self-report measure was from 9 to 3. So we thought we have done our job, and the patient did not come back for a second closure of the paravalvular leak. So we were happy that we could help this patient. This was the biggest paravalvular leak I ever closed, I tell you.
Wow. So I wanted to, that's a huge paravalvular leak. So I wanted maybe to understand why you chose an ASD device. Just because you thought it will give you the biggest waist area to occlude the leak, or was it because of the bigger disc to anchor?
No, it was because of the stent size. We wanted to have a stent as large as the paravalvular leak in order to have a more stable position of the device. Yeah. Right.
Yeah. I mean, that's a huge that's a huge leak. It's one of the biggest ones I've seen with tricuspid valve in valve, because valve in ring. This is the big challenge with doing tricuspid valve in ring is that you'll leak, but I have never seen one that big. Oh, good. We have a question from one of the fellows. Go ahead, Pierre.
All right. Yeah. Thank you. This is great. This is just, a shout out to you guys, because, when you think about interventional cardiology, you think about closing something that is open, opening something that is closed. And whenever you think about it, it seems so easy, right? But then you show with these two cases that you really need sometimes to think out of the box and, employ your creativity to actually help out patients. So that's definitely my first take, that these are great cases. And I was just wondering, for the second case, what do you think would there be any trouble if you were to actually implant the SD occluder first and then the sapien? What do you think about that? Thank you.
Yeah, very good question. A very good question. We thought the same, but the problem here is if you try to close the paravalvular leak first, the stabilization of the position will be inferior. If you have a valve in place, you have a much more stable position of the occluder. It could drop into the ring, yeah, and this is what we wanted to avoid. We had another case where we did the same, but then we had quite an obstruction of the valve by the occluder.
Oh, wow.
And yeah, this was really so we could occlude the paravalvular leak, but with a price of a significant gradient, transvalvular gradient. And our thoughts were to put just a second valve into the first valve in order to just to bring the occluder away. But the surgeons were willing to operate this patient.
Really?
They have done this. They have done this. 3 days later, she died. So these patients are really no candidates for surgery. No candidates.
Yeah, absolutely. Absolutely. And also, I mean, one of the ones I remember too was we put the valve in and there was a paravalvular leak, not as big as this, in this sort of extra ring space, and we left it alone. But then, the patient, they said, no, it's not doing well. You have to get rid of the paravalvular leak. So we put in, I think, 2 devices next to each other to close the leak. And then she died 4 days later because of acute RV failure. Because the RV needed a little bit of leak, and we were too good about getting rid of all the leak, right? So
what kind of occluders?
We used AV. It wasn't as big as this, so we put AVP2s, 2 of them next to each other, and we put. I think the largest one is like 16, 14, 16. We put 2 of them next to each other. And too good a result, unfortunately, because we got rid of all the PVL, but RV failed because of it. So it's they're very difficult patients, this.
Yeah, absolutely.
But I think also, I really like, I wonder if you could show it again so I can point it to the fellows. But when you snared and you pull the valve down into the ring, because I think that's really important in this kind of procedure. Because otherwise you don't deploy the valve in the right place. And that's correct. And this is a big problem. And that's why I really like the trick of the snare. So here I don't know if the fellows can see how the valve is outside of the ring?
Yeah.
And then Dr. Schofer pulls it down, and now he pulls it into the ring. Yeah. And that just tells you how big that paravalvular space is. And
absolutely.
Wow, that's crazy. Okay.
Okay.
Great case.
Okay, thank you. Shall I proceed to the next one?
Please. We can't wait to see the next one.
The final, the outcome of the final is different. I tell you.
Well, I appreciate
patient with severe regurgitation, because we have to be realistic. Mitral regurgitation at an unusual location, solving a problem and creating another. Okay. 82 years old male patient, a new onset heart failure, quite severe, 2 weeks before presentation. In association with a new murmur, systolic 4/6 murmur at Arab. He was on atrial flutter. Laboratory findings showed elevated NT-proBNP, slightly impaired renal function, anemia, no CRP elevation, no leukocyte elevations. This patient underwent bioprosthetic valve surgery, trifectas 27 millimeter surgery at 2017, combined with bypass surgery, Lima to the LID. Comorbidities were arterial hypertension, diabetes, peripheral artery disease, and as we mentioned before, atrial flutter. LV function was slightly impaired. So this is the echo of this patient. What you may see here is a gap at the basis of the anterior leaflet. This is almost an LVOT view. and you see a quite severe regurgitation through this defect. Let's say it's a defect. Very close to the aortic valve. The aortic valve itself looked fine with a mean gradient of 2, so nothing of concern. And if you see the 3D, you can nicely appreciate the slit-like defect here at the basis of the anterior leaflet. We did an MSCT revealing the same results, and the measurements were almost comparable to what we have seen in TEE. It was measured by 8.3 and here by 10 and 9 millimeters in 2 different views. And you see the close venicity to the aortic valve, to the aortic bioprosthesis here. And here again, in 3D, the slit-like defect at the base of the anterior leaflet. So any suggestions how this happened and what to do?
I mean, it looks like it happened as a result of the surgery, is what I would say. When you don't know what's wrong, you always blame the surgeon.
Yeah, that's correct. Either the anesthesiologist or the surgeon.
There you go.
Depends who is present.
Wow. I mean, that's very difficult. I mean, the thing I would think about first is, again, could I put some sort of plug in there, or even a PFO type occluder device in there? But the thing that worries me is, what's it going to do to the leaflet? You know, is it going to push the leaflet down? Is it going to impact leaflet function? Am I going to, cause now central and mitral regurgitation, or will I make the defect even bigger? I don't know.
Yeah. Correct. So the first, I had experience with one patient immediately after surgery, and the surgeons told me when they suture the valve, they can get too deep and could, in a way, sometimes lacerate the base of the anterior leaflet. This is one maybe possibility. In this case, the symptoms developed and the new murmur developed 4 years after surgery. 4 years.
Wow.
So there is one case report. I figured out there's one case report in 2017 published.
Yeah.
This is almost the same situation. 30-year-old male patient who experienced symptoms 4 years after surgery. And the hypothesis was that the pivotal guards of the prosthesis were protruding into the LVOT, leading to a perforation by diastolic movement of the anterior leaflet. This is it's a speculation, but I think it may make sense that this happens because we saw this. We saw this also in patients where we put the THV too deep. It has been described
with the core valve too
core
deep.
valve. Yeah, absolutely.
We've seen this.
Yeah. Okay, so this was the case here. So this was the picture during surgery. In this case, you see the slit-like perforation. This patient underwent mechanical valve replacement.
Wow.
So this is different to our patient.
Yeah.
Again, back to this patient, the patient denied a second surgery because he had so bad experience with the first one, and it was an elderly patient, pretty high surgical risk. So again, we thought about a closure device. Yeah, the same portfolio. Okay, what have we done in this case? We thought if we take a septal occluder, a 10 millimeter septal occluder, according to the size of the slit, it should fit because then we have we have then a 22 millimeter disc at the ventricular and an 80 millimeter disc at the atrial site, and this might not impact the movement of the anterior leaflet. So we thought, okay, we can try it, we can retrieve it. That's always the big advantage of using those closure devices. So we went transeptally with the Agilis sheath, took a diagnostic JR catheter, put a soft remove through the lesion, which was not so easy to find, but finally, with the help of 3D, we could achieve it. We then put a stiff remove very deep into the right pulmonary vein, and proceeded with a 6 French Cook sheath. Okay, and then started to deploy the device. This is again a 3D seeing after introduction of the Cook sheath through the lesion, to the defect, and this was the first attempt with a not completely developed distal disc. We put it through, and maybe you can see that in a minute. Yes, so we had to do it a second time with a fully deployed distal disc, and then brought it up. Yes, we brought it up to the anterior leaflet, as you can see here. An echo, always taking care that we don't pull through again. And after development of the second, we made some, we did echoes, and we're not very satisfied with this result, still quite a significant leak. But after several repositions, we came to a position which was, I think, quite okay. It was 1.5 hours later. This was the final result here. I think we think it's quite acceptable. We couldn't achieve it better.
Better than that, yeah.
This is how it sits here, and we had no significant regurg. We had no significant stenosis, and we still felt the anterior leaflet motion is not very much impacted. We had no LVOT gradient and intact aortic valve. So we thought, leave it here, disconnect, and see what's happening. Patient came back with severe hemolysis, requiring transfusion. Every 4 weeks, he had to be transfused, and there was a small trend for a, let's say, decreasing hemolysis measured by LDH at 3 months, but still, he is symptomatically, he has improved, but the drawback is that he still needs transfusions from time to time because of hemolysis. Yeah. And at that point, you know, our suggestion is that even, you know, if you have if you have a residual defect in a high gradient location, you have to expect a significant hemolysis. But in particular, I talked to a lot of people who have much more experience with closure pulmonary leaks, and the opinion is ASD and PFO occluders are not appropriate in a location with high pressure difference. So maybe it was the wrong choice. Maybe we should have chosen a vascular plaque, the biggest vascular plaque. Maybe this would have resulted in a even better closure, and for, especially in avoiding severe hemolysis. So this is, to me, a learning point, never to use a PFO or ASD occluder again for this type of lesions.
Yeah, we've had you know, with PVLs, because here in the US we don't have the AVP3. okay, which is my favorite device for mitral PVLs. So then we have to use other things, we use AVP2s, we use PDA2 devices, but there was once or twice we tried using a VSD device because, someone from Abbott said, no, they had great outcomes with it.
Yeah.
And we had such bad hemolysis afterwards.
Really?
Such bad. We were considering to go back and to go remove the devices because the hemolysis was so bad. So I think you're right. I think the ASD, PFO, VSD devices in mitral PVLs in high pressure situations are not great.
Yeah.
I've had a similar bad experience.
Okay. Yeah.
Wow, that's an interesting case. I'm not sure what else we could have done. We don't have any other really technologies, Joachim, for a patient like this, except trying to put a device there in that hole.
Yeah. So I also don't know.
Yeah.
I did another case. It went better because the closure was more complete.
Okay.
But also hemolysis was not so clinically relevant like in this case. But with this case, my decision is never using such type of occluder again in this situation.
In this situation, yeah. Again, I wonder how a Gore device would have worked here. The PFO device from Gore, just because it's all covered, right? All PTFE. I've seen a couple of case reports in the literature of people putting it in to treat a leaflet perforation, and people putting it in between two mitral clips where there's residual leak. But I've also heard of negative consequences from putting it in patients getting thrombus formation on the left side on the device, the device moving and tearing open the valve. So it's not easy. Manaf, I see you had a question.
Yeah, thank you, Dr. Schofer, for a great series of cases, very thought-provoking. And I think they highlight for me the reason that I kind of first fell in love with structural, which is the aspect of using a multifaceted toolbox in a creative way to come up with novel solutions for patients. And you demonstrated that exceptionally well with those three cases. Just to add on to I was thinking the same thing, Dr. Latif, about the Gore cardioform. The other thing that I think might be useful here is that it's a much softer device and may even allow for a little bit more motion of the leaflet, but I know availability in Europe is not yet there. My other question was about the second case, doing a valve in an incomplete ring. Were you worried about being able to anchor appropriately, or did you have any concerns about it being an incomplete ring? Because I know that's one of the issues that we sometimes discuss with incomplete rings versus complete rings, stability and anchoring.
Yeah, absolutely. So to be honest, I felt it quite safe to use this snare to just pull it into the ring, and as soon as it is really inflated, it's going to stay stable there. The drawback of the incomplete ring then is the paravalvular leakage, but what we always have to expect, in particular in the mitral space, but also in the tricuspid. But in this case, we had a huge paravalvular leak anyhow, so this was not of any concern. No, but if we didn't use the snare, I think it was not possible to implant this in a safe way. Yeah.
And I think also, Manaf, incomplete rings on the right side are different to the left. So the incomplete ring on the right, you saw in the picture from Dr. Schofer, it's actually more complete than the mitral one. So it doesn't touch, but it goes
extra.
Yeah, it covers most of the circumference, just leaving the triangle of Koch free. And it's also a low pressure system. So you don't get embolization. Whereas on the left side, it's a smaller ring. And so the problem is it's a high pressure system, right? You can get 200 millimeters of mercury pushing against the valve. And so they embolize on the left side with incomplete rings.
Yeah.
Right. Right. Thank you.
Jonathan?
Hey, good morning. First of all, thanks for these cases. I think we now are all awake. Two questions. First one about this last case. I was wondering, I mean, the surgeons, when facing a similar problem, placed a valve. I mean, there are more and more mitral valves coming up. I thought, for example, the Intrepid valve with this like also wider landing zone in the atrial aspect, might that be an option, maybe even with that atrial aspect sealing this part of regurgitation there towards the aortic valve, about this last case? And then in more general, I mean, in all your cases, you used some kind of closure device, but in all cases, there was some kind of residual leak or it had like hemolysis or other problems. So is there a gap that we need to fill with a different, another sort of device for such cases? And how would you imagine such device to fill this treatment gap?
Good questions. You know, just to answer the first question briefly, we didn't think about a percutaneous valve in this case because we don't have it available. But it would be, you know, because it's still in an experimental status also in Europe, beside the Tendyne. The Tendyne has been approved, but the Tendyne would not be a good option. A transapical implantation in this elderly patient would not be a good option, I think. Another valve, you know, I don't think that would have been accepted as a implantation in association with a trial. Yeah. The other thing, if we have a residual leak on the right side of the heart, I think this is not so really important because hemolysis is very rare on the right side. There, you just have to improve the patients clinically and should not be so afraid, let's say, of a residual leak which you leave behind. Yeah. The second case, you know, showed us that she significantly improved. So there's no reason to go back and try to close it completely. In the first case, let me see what we have.
Well, in the first case, I mean, I don't think there was much residual leak. It was very little, most of it thrombose. But I think, you know, Jonathan, you bring up an interesting question. We've often thought about, even for paravalvular leaks, because the shape is so irregular, can we design a device? And I think there was a group looking at it that maybe is almost inflatable, right? So you put the device, it's like almost like a balloon that's very compliant into the defect, and then you inflate it and it takes the shape of the defect and then seals. And then if you like it, maybe you swap it out with a polymer or something, like, you know, direct flow, like we did with direct flow. But the problem is, you know, the reason no one's developed it is because even though, yeah, we show you some cases with unmet clinical need and where we had to be, you know, Dr. Schofer had to do ingenious things, the market for something like this isn't huge. There's a number of procedures. And so companies want to develop things where they're going to make money and, you know, where they're going to get some return on the investment, right? And in devices like these, unless there's a lot of patients, you don't get a lot of return on your investment. But I think you're right. We need something that can conform better to the anatomy, to different anatomies, and also that gives you a more immediate sealing.
Absolutely, I agree.
So we'll wait for you to start helping us design something, Jonathan. You have your homework now. Sebastian.
Yes, I mean, thanks a lot. I don't really have any technical questions. I'm still stunned by the three cases. I wonder, actually, regarding all of these three cases, how do you approach the patient in these cases? In these cases, how do you? I mean, and secondly, what are your bailout procedures to these bailout procedures? Do you have any, or do you tell the patient, okay, this is your last chance, either it works or you die on the table, or how honest can you be with the patient? What's your approach there?
Yeah, in principle, you know, it's always a good position or a good situation if a patient is coming to you and has been denied from several other centers, but has a really a bad wish to be treated. Second point is, of course, one has to think about if it's responsible to do that or not. But in all these cases, we could have retrieved the system and leave nothing behind. Just, I think the chance to make it worse was very, very minor, but the chance to help was about 80%.
I think that's a very important place to stop as well, Joachim, for the day, because I think you summarize it very well. I mean, I think that they seem like extreme cases. There were patients who needed to be helped, and that's what we do in medicine. We always try and find solutions for patients, but I think we forget. I want to highlight for people watching as well all the thoughtfulness that went into it, the planning, the CAT scans, the evaluation in a team to, you know, really decide, is this patient a candidate? What device am I going to use? And then also Professor Schofer used the device where if he needed to, if it wasn't working, if it was making things worse, he could take it out, right? And go backwards and leave the patient where they were before. And I think that's also extremely important when you do these kind of procedures. Joachim, you blew us away again, as usual. You give us a lot to think about. Because also now, you know, I think many of us have seen these kind of patients where we wondered, could we do something? We didn't. And you're always at the cutting edge, forcing us to rethink about how we can help patients and come up with out-of-the-box solutions. I always learn from you, and I applaud you. And I'm very delighted to have you as a friend and to learn from you. Thank you so much.
Thank you so much, Azim. It was a great pleasure and honor for me to be part of this very, very interesting conference. Okay.
Let you go back to your patients. Take care. Okay. Bye-bye.